I'd like to introduce Andrew Cathers. Andrew is the medical director for MedFlight here at UW. He initially came just kind of to talk to our department, but just about a bit of an update on medical transport and MedFlight. But I asked him to give us more of an overview and history so that we could get kind of the who, what, where, and why we do medical transport and what we're trying to do to make it better. So, Andrew, I really appreciate you coming and taking the time to put this talk together. I think it's really important because actually a lot of the pathologies we take care of in trauma and stroke and things is really impacted by the quality of our med flight. So thank you very much.
Yeah, thank you. And thanks everybody for having me. Yeah, and so as Dr. Brooks mentioned, my name's Andrew Cathers. I'm the medical director for MedFlight and part of the emergency medicine and EMS and pre-hospital faculty. And so kind of speaking today on behalf of MedFlight leadership, so myself, Ann Rickers, who's our director of pre-hospital care and medical transport, and then Dr. Brazelton, who's one of our pediatric intensivists and the medical director of our pediatric neonatal specialty team. Just very brief background. I did medical school at University of Connecticut, grew up out east in Rhode Island. I trained in emergency medicine at University of Massachusetts, where I also flew as a flight physician. And then I came here for fellowship training in critical care transport and EMS, and that has kind of allowed me to have this job here where I've been faculty for I think 5 or 6 years now. So as Dr. Brooks mentioned, kind of the objectives of this are to review the history of medical transport, to describe the current history or current state of medical transport in the U.S., particularly in regards to helicopter transport. And then, towards the end to provide a little insight into our own organization's transport service and a little kind of plug for MedFlight. I think we were so close to being able to have this in person, but obviously this is virtual, but please feel free to either put questions in the chat or just interrupt me, or we can leave a little time for questions at the end. So I always like to start just with some cases to just kind of like set the picture and then provide some context. So this was actually a picture from Massachusetts where I trained. The first case that we'll circle back to at the end is a 25-year-old male involved in a high-speed MVC. He's entrapped in the car. There's what we call prolonged extrication, which means the firefighters and EMS are working over a period of time to actually free him from the car. There's reports that he has altered mental status, some snoring, respirations, and a scalp laceration. And so a helicopter EMS service has also been activated to come to the scene. The second case would be kind of the second facet of helicopter EMS. So this would be an example of interfacility transport of an elderly woman who's anticoagulated on Coumadin, who presents altered and very hypertensive with supertherapeutic INR and has a large intracranial bleed with a midline shift. And so, she's at a small facility. Maybe there's just one emergency medicine doctor. Maybe it's just staffed by a family medicine physician. And so a helicopter service has been activated to transfer her to a tertiary center with a neurosurgeon and neurosurgical ICU. So talking about the history of medical transport, this will be a fair amount of kind of cool pictures and things like that. And then we'll get into more actionable information later. Like with most things, especially in trauma care, the advances kind of came out of combat. And so in the Middle Ages, there wasn't a lot of battlefield medicine. Starting in the 1800s, you start to see people like this, what they called stretcher bearers or litter bearers, where the idea was they were primarily there to transport injured people off the battlefield and bring them back behind the lines to some sort of medical care. This then translated into the civilian world. So this is the first ambulance in the United States. This was in Cincinnati in 1865. And so the interesting thing with that is that a lot of these ambulances were actually owned by hospitals. And so there wasn't really, a way for standardized billing or anything like that. And so there were actually competing ambulance organizations. And there's actually reports of them literally fist fighting over patients because the idea was your hospital paid you to go get patients and bring them back to your hospital. And so there was just not a lot of standardization, minimal medical training, and just kind of some brutal competition between competing ambulance services. Obviously that improved over time, but it really wasn't until 1973 that it kind of took the next leap forward in terms of EMS. And so that's when there was the Emergency Medical Services Act of 1973, which was part of the Public Health Service Act and provided federal guidelines and over $300 million in funding to start to develop regional EMS systems throughout the United States. And so that was when we really started to step forward in terms of EMS. What's interesting is there are various models across the country and across honestly, the world in terms of EMS. So if you think about it, for the most part, first responders are kind of divided into three categories. You have the police, you have fire, and you have EMS. In the United States, EMS has traditionally been bundled in within the fire service. That's not necessarily true in other countries. A lot of countries, EMS is what we call a third-party service, where it's a separate service. In the United States, it's kind of been tacked on to the fire department, which is for a variety of reasons. And so it's kind of maybe something you don't really think about too much, but that's why when someone has a sprained ankle, or there's a cardiac arrest, or there's any sort of medical complaint, that's why a lot of times you will also see a fire truck there. There's not a fire, do you need a 50-foot long, $600,000 fire truck to go? Probably not, but because of the way the system is set up, most fire departments have a subset of their crew who are trained as paramedics, and oftentimes they will also have an ambulance. But typically the response is based upon also sending an engine and a fire truck, which honestly creates some inefficiencies, but is just how our system is set up. It does create some interesting challenges. I won't go too much into the politics, but paramedicine in particular is like a 2-year kind of technical degree after high school. And so it does not require a college degree. And because EMS is so integrated within the fire service, there's actually competing interests and actually a fair amount of pressure from some of the leadership on the firefighter union side, actually not to require a college degree for paramedicine or higher training, because that would affect obviously budgets and all sorts of things. So it's actually a subject of pretty intense debate about the need for increased education or higher educational requirements for EMS providers in the United States. And a lot of that is due to the fact that it is bundled within the greater umbrella of the fire service. I'll draw a few comparisons to other countries, which obviously have their own challenges with their healthcare system. But for instance, this is actually a degree in England, where paramedicine is typically a 4-year undergraduate degree. And then a lot of paramedics also have a 2 years master's degree. So it's almost more equivalent to a physician assistant almost, with that kind of 4-year undergrad, 2 years graduate program. And so, these services tend to be third-party services. They're separated from the fire department. The fire department fights fires. The police responds to police calls. And then there's a dedicated EMS agency that will only respond to EMS calls. Where I trained in Massachusetts, we had Worcester EMS, which was a really good paramedic service. And they were just an EMS service. In comparison, here in our city, Madison Fire has a subset of, has the EMS service within it. And they're also very highly functioning, really good service. But that's just an example of how we do not have a third-party EMS service in our city. It's folded under the Madison Fire Department umbrella. And so when we think about EMS in general in the United States, there's kind of two main roles EMS serves. Typically, one is called 911, which is basically you call 911 and EMS will arrive. Some people refer to this as primary responses, but that's the most common role for EMS. And that tends to be filled by public service organizations. So the fire department, as mentioned, kind of state-run organizations typically will respond to 911 calls. And then the second aspect of EMS is then the transport aspect. And so that's interfacility transfers, moving between hospitals. And so in the United States, this tends to fall more into the private organization realm. So just for example, in Madison Fire does the vast majority of the 911 calls. However, when we're transferring a patient from the American Center to UW, we actually have an agreement with Midwest Medical, which is a private organization that will do that interfacility transfer. This can create some complexities. For instance, we have a STEMI patient at TAC and Midwest Medical isn't available because all their trucks are busy. We'll actually call 911 and call Madison Fire to transport, do an interfacility transport, a STEMI patient down here. So the kind of the fragmented system does create some challenges there. This is a picture from my friends over at Boston MedFlight. And then when you think about EMS, right, there's basically three modes of transport, right? There's an ambulance, which is ground, which is by far the most common. There's a helicopter, which is really rotor wing transport, right? It is an air ambulance. So even though obviously we're biased and we think helicopters are so cool, at the end of the day, they are an ambulance and they kind of fit within their role within the EMS and healthcare system. And then you have fixed wing, which would be, a plane like this, a turboprop, a Learjet, some sort of plane like that. And so EMS, you kind of have 911, you have interfacility response, and then you have how do you respond? You respond either via in an ambulance, in a helicopter, or in a fixed wing. And so now delving more specifically into the history of United States helicopter EMS, and a lot of this work, I have to give credit to Dr. Michael Abernathy, who's one of our faculty. That's an awesome picture of him back in 1992 working for MedFlight. And then this is a more recent picture. He's probably like the most experienced flight physician in the US, and he's also done a lot of lecturing and a lot of work on the history of United States HEMS and medical transport in general. And so I owe a lot of the old pictures and things to his help. So we talked about stretcher bearers in the Franco-Prussian War. The first time anyone did air transport was actually in the Crimean War, where a subset of injured soldiers were actually transported via hot air balloon from the front lines back to the rear lines. That wasn't very common. There were also some experiments using Zeppelins and other lighter than air aircraft to transport injured patients. But it certainly wasn't a very common thing. Like we talked about earlier, most things come out of combat and war. And so I don't know, I vaguely remember the show MASH when I was growing up. Some people might remember it more, but this was based out of the Korean War. And you can see this, this is actually a patient strapped down to a stretcher on the outside of the aircraft. And so there was little to no medical care provided. They basically just picked the patient up, flew them back to the, surgical base, and essentially hoped that they kind of survived the transport. And that was the first time we really started extricating patients and bringing them to medical care using helicopters. This continued through the Vietnam War, and it has continued, obviously through this day. As we've gone on, we've started to get better and better at actually increasing the medical skill provided. And so it's become not only about bringing the patient back to the medical facility, but also the military now is highly trained combat paramedics and also some forward physicians and other medical professionals who are able to provide medical care where the patient is, stabilize them, and then transport them back. In terms of the civilian world, the first civilian medevac, helicopter EMS mission was in 1970. And so it was actually the Baltimore State Police, Maryland State Police out of Baltimore. And so they, a state police pilot and paramedic were dispatched in a state police helicopter to the scene of a crash on the Baltimore Beltway. And that was kind of the first medevac mission, which, actually doesn't seem that long ago that this just started to become a thing. And I do want to give a shout out. So that is still a program that exists. This is a modern picture. So it's actually interesting. The Maryland State Police run the helicopter EMS in their state. They do almost all 911 calls. So basically car accidents, things like that. But now they have these big, beautiful aircraft. They have a really good program. And all of their paramedics, primarily paramedic program, are actually state police as well. So just kind of cool to see that first program is still surviving today with a lot of the pressures that we'll talk about. This was the first kind of civilian program, so not associated with the state police. This is Flight for Life Colorado, actually, in 1984. And you can see this helicopter actually has wheels, but it also has little skis so that it was able to operate in the mountains of Colorado. And then in Wisconsin, in same year, 1984, this is Flight for Life, which was associated with the Medical College of Wisconsin. And then in 1985, University of Wisconsin got our helicopter. So this is the first MedFlight helicopter from 1985. So all the programs I've talked about so far are what we call hospital-based programs. And so we're going to get a little into the law and finances here, but it's important to just kind of understand some of the environment. And I think hopefully, if nothing else, it'll help people realize some of the competing pressures, especially once you get out into kind of the real world and out of residency that exists in American healthcare today. So all of these programs were hospital-based. So the University of Wisconsin, Medical College of Wisconsin, University of Colorado, University of Massachusetts, they got helicopters. The idea there was that they were going to have a good helicopter. They were going to go out, provide medical care to the patients in their community. And then also they were going to bring that patient most likely back to their hospital. There wasn't a real good reimbursement structure for this. And so there was a committee called the Ashbeams Committee that did some research, and they looked at the actual cost of running a helicopter EMS program. They based this on using good mid-sized twin-engine aircraft with experienced crews, the majority of which were physician-nurse-based crews. Almost all helicopter programs started as physician-nurse. For a variety of reasons, that model has changed, which we can talk about. And they weren't trying to make money. They just wanted to be able to run a sustainable service and to be able to provide for their patients. So they basically in 2002, they were able to successfully lobby for increased reimbursement based on this model of this hospital-based program. Unfortunately, there weren't a lot of parameters set within that. So they didn't really say, oh, you need a nurse paramedic crew, you need a critical care nurse, you need this equipment, you need this kind of helicopter. They just said, okay, yeah, we'll just give more money for helicopter transport. And interestingly enough, even today, our billing and our reimbursement is not based on medical care at all. It's one of the big limitations of EMS in general. It is based entirely on what is called a liftoff fee for when we take off, and then loaded mileage, which is just how far you transport the patient. So we will get, bill the insurance company more for someone we transport 90 miles and do almost no interventions than we would for an Ecmo patient that we transport 10 miles. And so that creates a lot of interesting complexities. I mean, I don't have the best comparison to neurosurgery maybe, but it would be like if all your surgeries were billed solely based on how many suture packs you used and not really, actually what you were doing with the patient. And so, as you see, as more money comes in, right, then this tends to then drive motives for better or for worse. And this is when you start to see the community-based program. And so these are programs that are not associated with a hospital. Because there's not a lot of regulations, you can just start your own helicopter program. There have literally been business people who have just started a helicopter program wherever they want. They don't need a hospital. Majority of them are for-profit and privately owned. And one of the other challenges is they don't have this idea of downstream revenue. So even with MedFlight, we're financially stable in amongst ourselves, but there's also the concept that most of our patients we bring to Madison, and there's this idea of where there's downstream revenue to the hospital. These programs are operating purely on just performing these transports without any potential downstream revenue. And so this creates a lot of problems. There was overexpansion, there was uncontrolled growth, there was overutilization, people using helicopters maybe when they shouldn't. And then there was just a lack of regulation. There was a huge spectrum of aviation abilities and medical crew experience due to this lack of regulation and the entry of these private for-profit entities. So the states then tried to intervene. For ground EMS, you need a certificate of need, and there is a fair amount of regulation. So, I couldn't just start, West Madison Fire Department and buy an ambulance and a truck. I would need to go to the state. I would need to prove that it's necessary. I would need to provide a lot of documentation. So it made the perfect sense to try and do the same thing for helicopter EMS. And this is where it gets really kind of weird with the lawyers and everything like that. So in the 1970s, there was a thing called the Airline Deregulation Act, which basically prevented the state and federal government from regulating airlines. And so this promoted competition and kind of capitalism among the airlines. So you got to choose, whether you flew Southwest or you flew Delta, and they would have to compete amongst their prices, and the government couldn't tell them what to charge. So there was a lawsuit where a private air ambulance company basically argued that they should also fall under the Airline Deregulation Act, and they won, which basically means the federal government does not control the air ambulance industry. And actually, even MedFlight, technically our aviation license, we operate almost as if we are a commercial airline, which is crazy. And so there's no limit on the charges that people can charge. There's not really any limit on the location of bases or service areas, the minimal aviation requirements, and then not a lot of requirements about medical crew and education. And this has all happened probably in the last 20 years. This is the number of emergency medical services helicopters. You can see it has really just gone way up, even from the year 2000, which is right around when this happened. You can see it's gone up, it's more than doubled. And it's not like the population of the United States has doubled in the last 15, 16 years. It's really been a function of increased reimbursement and the increased entry of the for-profit private model. So in 1980, we had 39 helicopters, and now we have over 1,000 in the United States, which is a lot. And you can also see, as there's been no regulation on the charges have also gone up, and 380% increase between 2007 and 2016. A lot of this data is not public, so that's why some of these charts are a couple years old. But you can see this has created issues where, it's capitalism. So they can charge more and they'll continue to charge more as much as they can. This is a map from 5 years ago or 6 years ago, looking at distribution of helicopters. And so what you'll notice is that there's a real huge swath of helicopters kind of through the Appalachian region. And when this has been studied, it's basically been found that helicopters tend to be clustered where reimbursement is highest, not where medical need is highest. And that's because most of them are for-profit and privately owned. So, if you look through here in Kentucky, Tennessee, there's tons of helicopters. However, if you look at South Dakota, right, which is a state where you would think, wow, like the distances are huge, there's not a lot of medical facilities, they must really need this service. There's only 3 helicopters there. Wisconsin is pretty middle of the road. We actually have a pretty reasonable environment. So we have maybe like 11 helicopters in our state. That's in comparison to Missouri, where there are 15 helicopter bases within an hour drive of St. Louis. St. Louis is a city not much bigger than Madison. And so that would be like if there were 15 helicopters within an hour of Madison. And these are all programs that are competing with each other for patients. And part of that is because Missouri pays really well in terms of Medicare, Medicaid, and private insurance reimbursement for helicopter EMS transport. So there's been this exponential growth, mostly in the for-profit sector, movement away from hospital-based programs. And this has created some quality issues as well. So private equity has been moving into medicine quite a bit in a lot of places. I mean, a lot of dermatology practices are starting to be acquired by private equity. I know in emergency medicine, they've acquired a lot of community-based places. I can't speak for neurosurgery, but just something to be aware of. And so the majority of air ambulances are actually owned at the end of the day by two private equity firms. And those firms basically view this as a subset portfolio of their portfolio. So this is one of their businesses that they run. They're not really a healthcare business. Their goal is to make profits and return it to their shareholders. And so there's basically two ways to do that, right? You increase your revenue or you decrease your cost. And that's when you start to see things like this, right? This has started to become more prevalent in the last couple of years. You'll see news stories about very expensive, 10-minute helicopter ride that they get charged $50,000. These are almost always from private for-profit companies. And they will also do balance billing, where they will actually then, if the insurance company won't pay, they'll then bill the patient. Sometimes they've even put liens on people's houses because they haven't paid their bills. Just really aggressive billing with the main goal being to make a profit. And it's not really fair because it's not truly a free market because the patient typically isn't determining whether or not they take a helicopter, and they're not determining which helicopter they take either. We actually had a recent case where a hospital called us, said they probably had a flight for us. We were preparing to go on the flight. The secretary then tried to call us back to confirm that they wanted us to come pick up the patient, but she read the number wrong and she dialed a different helicopter service. And that service ended up coming and getting the patient. That probably cost the patient somewhere between $20,000 and $30,000, depending on their insurance, just because we're a not-for-profit program that is very cheap comparatively. And it's like those little decisions that kind of create big downstream consequences. And part of that is due to the lack of regulation in the industry. As mentioned, right, when you're trying to make profits, you increase revenue. The other thing you do is you decrease cost. And so there have been safety issues too, particularly over the last 15 years. There's been a move towards increasing number of smaller helicopters with single engines as opposed to twin engine helicopters. And that's because there's not a lot of requirements for what classifies as an air ambulance. And so even though it's not necessarily the single engine that determines the safety, most single engine helicopters can't do instrument flying. Most of them do not have autopilots. And so your safety margin is a lot lower in a much cheaper single engine aircraft than it is in a large twin engine aircraft. In comparison, I love America, but in comparison, Europe, they have very strict air ambulance requirements. And actually 70% of air ambulances in the United States would not be legal to fly in Europe. They would not allow them because they do not think they're safe enough. In comparison, so Norway has a state functioning healthcare system, which has its own challenges, but their helicopter program is pretty renowned. And they operate basically anesthesiologist, intensivist, dual-boarded physician nurse model. And they have their helicopters kind of very rationally spread across their country, well spaced out, and they have a centralized transport system. So as far as what's, we're going to do, so Dr. Michael Abernathy, I talked about, he was recently named to a federal Department of Transportation committee. And so he's been working with the FAA and with the government to try and influence some of these factors, which has been really awesome to see someone from our department kind of on the national stage trying to make change. And there's also been the recent No Surprises Billing Act, which just started this year, which we're hopeful will help prevent some of this balance billing and kind of the surprise billing for out-of-network people. And then finally, there's just last week, there's also been our aviation partner recently split from one of the government organizations. over a lawsuit that was founded. So just a lot of movement in the area, and it'll be interesting to see what happens. So if we look at the current state, so this is an example of a snowplow. And then, this is also a snowplow. In the current state, you would be able to bill the same amount for both of them. And so this is an example of a common for-profit, private helicopter. This is what we call an A-Star. It's a small helicopter. It's single engine. There's no autopilot, so the pilot has to fly it by hand the entire time. And this is actually the medical kind of crew cabin. And you can see that the patient actually shares space with the pilot. The patient's legs are right next to the pilot because the helicopter is so small that they don't have a dedicated kind of medical patient compartment. And so that obviously can create some challenges there. And you can see the medical crew also don't, necessarily have the best access to the patient due to the size of the aircraft. Variety of medical crew compositions exist. This is not like codified by any sort of regulation. As mentioned, most programs started with like a physician nurse model. This has moved to a nurse paramedic model. And there are excellent nurse paramedic programs out there who do amazing things. But you've seen this trend, right? It first was like nurse physician, then it was nurse, and now it's nurse paramedic. And there are even some programs who primarily do scene response who have gone just paramedic, or just paramedic, a single paramedic program. And you have to wonder, right? One of the competing interests there is that this is becoming cheaper and cheaper to staff if your primary interest is in making money. In terms of regulations of even medical training, it's not that regulated. So CAMES is a voluntary organization that programs can join, but even them to have the ability to intubate, you have to perform only 5 intubations, and they could be on a mannequin, right? So if you imagine our anesthesiology colleagues, I mean, before they're intubating on their own, right, they have hundreds of intubations. I certainly had hundreds through my emergency medicine training before I became an attending and, intubated people in critical situations. But you could have a provider on a helicopter air ambulance who is doing an intubation on an ill patient who has potentially never intubated a live person before. And so these are where you start to see these potential quality issues. So that's the essential kind of diagram there. So now, how is this relevant, obviously, to your practice of neurosurgery? And so you guys will often take calls for interfacility transfers. And so due to EMTALA, right, the mode of transport is determined by the sending physician. However, you can certainly influence that or at least provide some guidance. Unfortunately, we don't have Star Trek kind of teleporting technology. And so the patients do have to get moved one way or the other. There's differing scopes of practice for EMS. I think the important thing to recognize here is that there are EMTs who have about 3 months maybe of training and relatively limited skills. And then there's paramedics who have about 2 years of training, much higher skill level, can start to give medications and do intubations and things like that. There are some certification for paramedics. I won't go too much into this, but know that this area, there's not particular training requirements. It's a test that if you pass, you get this, but it doesn't require an additional, year of coursework or anything like that. And so when you're accepting transfers, one thing to think about is the kind of the level of care the patient needs. So BLS would be just an EMT basic typically. ALS would typically be 1 paramedic. Critical care transport is where you start to get into at least 2 paramedics, if not a paramedic nurse, or in our service, a physician nurse. And then specialty transport is kind of a separate thing. The mode of transport also matters. You have air ambulance versus ground ambulance. The helicopter is just an ambulance. However, it is a lot of times a filter. And so if a helicopter is utilized, that will almost always bring with it a nurse and some specialized training. And so typically the helicopter will have a higher level of care they can provide. So now bring it home and talk about med flight. So brief history of med flight and kind of EMS in Wisconsin. This was the bus, which was in the 1970s by Dr. Marvin Birnbaum. And this was the first kind of pre-hospital entity within our city. And so as a bus, they would go to outside facilities. They had a stretcher, they had medical equipment, and they would start to provide care to people out at the outside facilities. 1985, MedFlight was launched. The idea was that this was part of the Wisconsin idea where, we weren't in it to make money. We were out there to provide, to expand the reach of the university and our healthcare out to the entire state of Wisconsin. So a nice, cool old picture over Lake Mendota. And then this was kind of the first group of physicians and nurses. Several years ago, we merged with our pediatric and neonatal partners, which was the Cheetah team, which some of you may be familiar with. And now we just are under the one MedFlight umbrella, doing both ground and air transport of neonatal, pediatric, and adult patients. So we talked about some of the other helicopters, and some of these helicopters do exist in our region. We are fortunate where we actually, I think, have very high capabilities. So we fly with an attending physician, emergency medicine physician, making us one of the few programs in the country to still do that. We fly with very skilled nurses, one of the most competitive nursing positions in the hospital. We have the ability to do ultrasound. We can do chest tubes. We can do field amputations. We carry blood products, 4 units of packed red blood cells, 4 units of plasma. We can do Ecmo transports, balloon pumps, nitric oxide, kind of a lot of really cool stuff. And part of that is due to our aircraft. So we fly very large twin engine aircraft that can do instrument flying capabilities and are much more expensive and much more high functioning than a lot of the other aircraft. You can see here, kind of, this is a picture of the back. So there's a lot more room. We're able to access the patient. We have a hospital quality, ICU quality ventilator, and just a lot more ability to do medical care as well. And at night, for safety reasons, we also have night vision goggles, which is just cool. And I'd be happy to show anybody sometime if you guys want to come up. With this, we're obviously aggressively recruiting really talented people. And so I always want to give a shout out to this. This was our first all-female flight crew. And I think this was still the most popular UW Health social media post of all time. This was about 2 years ago. We had our first all-female flight crew. So pilot, nurse, doctor, and these are all like awesome, really talented people. We don't do just helicopter transport. We can also respond via ground, depending on patient and weather conditions. And really, it's just, about critical illness doesn't respect geography. Wherever you get sick, we're trying to elevate your level of care and to be able to bring kind of that UW Health level of care out to the patient. In terms of our locations, so we are located in Madison initially for the first 31 years. We've been expanding over the last 5-6 years. We now have a 3rd helicopter in Portage, Wisconsin, and another one in Iowa County, Wisconsin. And we're planning on also moving one of our ambulances and one of our aircraft down to Janesville, which will bring us closer to Beloit and our partners in Rockford and kind of the southern part of the state. And part of the reason for this is even in Wisconsin, there's a lot of competition. So there was a private for-profit program that actually just started in Hartford, Wisconsin a year ago. We think they're probably already going out of business, but it's not really clear. There was a for-profit program that moved into Dubuque. There's Flight for Life, which is a not-for-profit program associated with Freighter, recently moved into Burlington, Wisconsin. So there's just a lot of movement and a lot of potential competition. And so even on our side, as a not-for-profit program folded within the hospital, we still obviously have a bias towards our services and also think we provide a really high level of care to the patients. So here's a picture of some of our helicopters. In terms of things we do, we talked about ECMO and inhaled nitric oxide. This is an example of an ECMO transport right at the start of the COVID pandemic. That's Scott Niles and Dr. Charles McCarthy, who's Dr. Dan McCarthy, who's one of our cardiothoracic surgeons. And so we're the only program in our region that has the ability to go out and to cannulate patients onto ECMO and then to transport them on ECMO. And then we also obviously do a lot of scene flights. This was a good example from last year. There was a patient who actually was trapped in a corn auger in a silo, and so our crew actually flew out, did a procedural sedation, and performed a pre-hospital amputation of his lower leg in order to free him. The patient survived neurologically intact, so that's a good example of some of the scene responses we're able to do. And then finally, we have our pediatric neonatal subset, which I'm happy to talk about further, but maybe not super relevant to neurosurgery. But we do isolate neonatal transports, oscillatory ventilation, and a lot of really good work there as well. The foundation of our program is safety. So obviously we train a lot. We do survival training. We do simulation training constantly. We're CME accredited. We have our own morbidity and mortality conference. And we do a lot of things to try and keep our level of safety and abilities high. Kind of looking forward at the future. So our volumes have continued to climb, which has been great. This is combined ground and air transports. And our mileage per transport has increased over the last several years. As we've had larger aircraft, we've been able to take patients from farther away and transport them farther. We've flown patients from the UP. We've flown patients from Reedsburg down to Peoria. We have the ability to fly to Chicago, all sorts of places. And we don't only bring patients to Madison, we'll also bring them to other places. And so as far as the future, I think the future looks bright. The No Surprises Act and some of these changes we think will help programs like ours in that we are not-for-profit, hospital-based, and we think it'll help drive maybe some of the for-profit private entities out, which will then help us utilize our own services. And we're just going to continue to try and increase our utilization and also our skills as well as our efficiencies to kind of better serve our patients. And with that, I actually am going to stop here just to give people 3 minutes to see if there's any questions or anything like that.
Hey, Dr. Cathers, this is Dial Buckley. I'm one of the fourth-year residents here. Thank you so much for a terrific talk, really thought-provoking, and it's really nice to see the history of MedFlight. We're very lucky to work alongside the MedFlight folks. So I just had a question with regards to, you mentioned that you do an M&M type conference, and specifically with regards to M&Ms, how do you follow your patients that get transferred in, or does your M&M look specifically at the care rendered and outcome during transport, or do you follow patients into the hospital setting and say, look at people who have been transferred and the proportion of which, do well, get discharged, or pass away, say in the first 30 or 90 days? Just sort of what the metrics are and what you guys look at.
Yeah, great question. So yeah, we have a pretty robust quality program. So I'm one of the academic faculty here as well, and I sit on the quality committee. So yeah, we're able to follow patients throughout their entire stay. There's different metrics we look at, and then we do for the M&M, we will follow and do case follow-ups and things like that to see how they do. And then also we're integrated. I also attend, the trauma peer review committee and all those things. So we get feedback that way as well. Even if we bring patients to other hospitals through Care Everywhere, as well as good relationships with those hospitals, we're also able to get feedback there. So we don't specifically track like 90-day mortality, although someday I do think that would be an interesting study because our patient population obviously skews towards very, very sick patients. But yeah, we cover both the transport as well as then obviously what kind of happens to them afterwards, looking at anything we could have done better during our time with the patient.
Thank you very much for that. Yeah, just to follow up, then if you do look at the outcomes over time in their hospital, for their hospital inpatient stays, do you feel like there's any way or any room for improvement in terms of communication between the subspecialists that people are being referred for, say transplant, say neurosurgery, trauma surgery, maybe even orthopedics? I'm not sure. Any way to improve the efficiency of the system with communication?
Yeah, well, it's a big question, but it's a good one. Yeah, There's definitely ways to improve that. I mean, and a lot of times we're kind of an intermediary. So oftentimes we won't even speak to the neurosurgeon. They'll have spoken to the outside hospital physician, and then we're kind of there to help manage that. Obviously, if necessary, we can reach out. I think we've been working on co-locating our dispatch center with our access center, and Ann Rickers has been doing a lot of work with improving our access center. So I think as that improves and as the technology improves, we'll be able to all have a more consistent plan and better communication using Haiku and other abilities like that. So yeah, I definitely think room for improvement, but not that it's terrible, but there's always room for some improvement.
Thank you.
This is David Neiman. That was a great talk. Really interesting how it all works. I'm one of the cerebrovascular neurosurgeons, so a lot of our stroke patients is what I was thinking about. The biggest delay in stroke is from when we tell the outside hospital, yes, it's a go, we'll take the patient. The biggest delay is always the transport part. It's so variable. And it may have to do with ambulances even more than flights. Do you see anything coming down the road? Like, how do you and the for-profit places and stuff, is there any legislation or cooperation if people are actually trying to get money? I've had situations where the patient could have got here faster, but the hospital had an agreement with a different transport company, so they went with them and stuff like that. We just find it vexing where there's potential improvement in from time go to getting the patient to our building. Do you see anything coming down the way with that for a systemic approach to the fact that there are these competing forces and competing ambulances? We do have hospitals call 911 when we can't get someone to get over here. Like, we've had delays even from Meriter. Any thoughts on that stuff?
Yeah, I agree. Vexing is the right word. And, I'm biased towards MedFlight, but especially for a lot of these patients, like if they're in Wausau, the Wausau helicopter is going to probably be the best, way to get them down. So I'm not saying, not a huge bias towards MedFlight. I agree. There's not a lot of regulation. And so at the end of the day, it's up to the sending physician. It's challenging. I think maybe with some of these changes, maybe some of these competing forces will drop out. And if nothing else, it'll become more clear what services are available. As mentioned, there's a for-profit program in Hartford, and we don't even know if they're operating. Some days they're not there, some days they are. It's literally run kind of like a business. So there's a lot of challenges with it. I think we do still work together. So if we're not available, like, we will call competing services, because at the end of the day, we want what's best for the patient. And then I think specifically on the MedFlight side, we've been doing a lot of things to improve our operations. So we've started doing hot loading. So we'll keep the helicopter running, go in, get the patient, come right out. We've been doing a lot of that work with NES patients as well as STEMI patients, and we find that's cut our transport time down by quite a significant amount. But in terms of like a statewide, nice transfer system, unfortunately, I think with all the competing healthcare systems, I don't know if that's a reality of like a rational functioning transport network, which is unfortunate.
Seems like more of a regulatory change would be needed, and this is something that I think is important.
I think so. And and I don't certainly want to always be pushing for government regulation and things like that, but I think when you have all these competing priorities and health systems that are going to be biased, and you have private companies that won't there's a company who wouldn't do a ground transport unless the patient came up with $8,000, and they're a private entity and they're allowed to do that. So I think there's just a lot of suboptimal things within this area. But we obviously biased. We are the good guys. So we're actually in the cheapest quartile, despite providing probably the highest level of care. And we're folded within the UW system. So
that's great. Well, I appreciate your time on this. This was a really interesting and great talk. And I think very relevant for every subspecialty in neurosurgery, and then of course throughout the hospital. So thank you very much. Any other questions, the crew? All right, thanks Andrew, appreciate it.
And you guys can email me or just see me in the ER and let me know if you have any other questions.
Thank you. Have a great day. Bye everybody.